Imagine your vision suddenly splitting one moment you see clearly, the next, well, double. Now, what if that clears up, only to return weeks later, this time affecting the other eye, and bringing with it this relentless, throbbing headache?
Yeah, it's a really bizarre scenario.
What kind of medical culprit could possibly be behind this neurological, like, ping pong in a seemingly healthy 67-year-old woman?
That's the puzzle.
This is the medical puzzle we're cracking open today. Get ready for a diagnostic detective story. It's got unexpected twists, some dead ends, and then a final surprising revelation that really hinges on a single, crucial lab test.
It's quite a journey.
By the end of our deep dive, you'll not only understand this unusual illness, but also appreciate the fascinating journey of how doctors actually piece together such complex cases.
So we're focusing today on a 67-year-old woman who came to the hospital because she was experiencing a persistent headache, along with a troubling pain located right behind her right eye.
Okay, so this wasn't just out of the blue, though. Actually, about 10 months before this hospital visit, she'd developed a rather striking rash on her forearms. It was red, bumpy, and seemed to be quite sensitive to sunlight. Interestingly, this rash appeared shortly after she started taking a medication called hydrochlorothiazide.
Yeah, that timing is definitely suspicious.
It makes you wonder if there's a connection there, right?
Absolutely. That's a very astute observation. And that initial rash wasn't the end of her skin troubles either. Over the next 7 months, she developed another type of rash. This one was intermittent, didn't itch or hurt, and it was characterized by these red, ring-shaped patches.
Annular, they call them.
Exactly, annular. They appeared on her trunk and the upper parts of her arms and legs. So already we have, a few different pieces of the puzzle starting to emerge.
Right, skin stuff first. Now, let's fast forward a bit about 3 months before this latest hospital visit we mentioned. These rashes decided to act up again. They worsened. Understandably, she sought medical attention and saw a skin specialist, a dermatologist, at a different hospital. Some initial tests were done. Her thyroid levels were normal.
Which is good to rule out. Thyroid issues can cause skin problems.
Right. But a biopsy taken from one of the rashes on her abdomen provided a bit more information. It showed some inflammation in the skin, spongiotic dermatitis, along with certain immune cells. Eosinophils were mentioned, but importantly, it didn't show any signs of vasculitis, blood vessel inflammation, or a buildup of something called dermal mucin.
So it showed something was wrong, but not exactly what. Not a specific diagnosis from the biopsy itself.
Exactly. Based on these initial findings, the doctors suspected, well, maybe it is related to one of her medications.
Back to the hydrochlorothiazide, perhaps.
That was the thinking. It was stopped, and she was started on a different blood pressure medication, amlodipine. She also got a topical steroid cream, triamcinolone.
And did that help?
It did, thankfully. It helped clear up both the sun-sensitive rash and that ring-shaped rash on her trunk. So for a little while, it seemed like they'd addressed the problem.
But the story doesn't end there, does it?
No, definitely doesn't. Here's where things take another unexpected turn. Just 10 days after that dermatology visit, so about 8 weeks before this current hospital admission we started with, she found herself in the emergency department of a second hospital.
Okay, different hospital again.
Yeah. This time, the issue was a 3-day history of a really severe headache on the left side of her head, specifically the temple area, along with a deep pain behind her left eye.
So completely different symptoms now. Neurological, not skin.
Totally different. What could be triggering this now?
At that point, the doctors did a physical examination and everything seemed normal. They also checked a general marker of inflammation in her blood, the ESR, or erythrocyte sedimentation rate. It was only slightly elevated, 12, not dramatically high. Her routine blood work, checking blood counts, electrolytes, liver, kidney function, all came back within normal ranges.
So they were looking for answers, but the initial tests weren't really giving many clues. Pretty frustrating.
Very.
To try and get a clearer picture of what might be causing this intense headache, they decided to do some imaging of her brain. A head CT scan showed some mild changes in the white matter.
Which is pretty common, chronic small vessel disease, often seen with age and hypertension. Usually not the cause of acute, severe headache.
Right, nothing acute. They also did a CT angiogram, looking at the blood vessels in the head and neck.
To rule out things like aneurysms or blockages.
Exactly.
Yeah.
And that also came back clear. No aneurysm, no stenosis, no occlusion. So without any clear answers, she was discharged home.
Wow, okay.
You'd think that would be the end of it for that episode, but the very next morning brought a frightening new symptom.
Oh no, what happened?
She woke up experiencing double vision.
Double vision, diplopia.
Yeah. The headache was gone, which was, a relief, I guess. But this new visual disturbance was alarming enough to prompt her to seek immediate medical attention again.
I would think so. Where did she go this time?
She went to a neuro-ophthalmology urgent care clinic, actually connected with the first hospital where she'd seen the dermatologist.
Okay, back to the first system. So now she's dealing with a completely different set of neurological symptoms. What did the specialist find there?
She told them the pain in her left eye was still lingering, and it actually got worse when she tried to move her eye outwards, abduction.
Pain with eye movement, that's significant.
She was also experiencing increased sensitivity to light, photosensitivity, and interestingly, she mentioned having had jaw pain on the left side in the past week.
Jaw pain too. Okay, adding more pieces.
But despite these issues, her basic visual functions like acuity, color vision, peripheral vision were all normal. And the back of her eyes, the optic discs, looked healthy.
So the nerve itself looked okay on exam initially?
Initially, yeah. However, when they examined her eye movement very closely, they noticed her left eye was turned slightly inwards and upwards, esotropia and hypertropia, and she had real difficulty moving it outwards.
Ah, limited abduction. That points towards the sixth cranial nerve.
Exactly. It seemed like the nerve controlling that outward movement wasn't working properly. A sixth nerve palsy.
Did they repeat the inflammation markers, the ESR and CRP?
They did. Showed a similar picture to her previous ER visit.
Yeah.
Slightly elevated ESR, mildly elevated C-reactive protein, or CRP. Nothing sky high.
Okay. So based on these findings, the doctor suspected an acute left sixth cranial nerve palsy, likely caused by cerebral microvascular disease, a temporary disruption of blood flow to that tiny nerve.
That was the leading theory then.
It often is in these situations, especially with vascular risk factors like hypertension. They recommended patching her eye to help with the double vision.
And did that work?
Thankfully, yes. The patching helped manage the double vision, and it actually resolved completely over the following 3 weeks.
Okay, so crisis averted again. Seems like it.
It seemed like it. Another crisis appeared to have passed. But as we know from the start, this wasn't the end of her medical journey.
No, not at all. Fast forward another 8 weeks, and she found herself back in an emergency department, this time at a third hospital.
Third hospital. Wow. Okay.
The symptoms were eerily similar to that second hospital visit, but now they were affecting her right eye.
The right eye this time, so it switched sides.
Switched sides. She had a 3-day history of headache and pain behind her right eye, and this time she also noticed changes in her color vision and occasional floaters.
Changes in color vision, too. That's concerning for the optic nerve itself.
Yeah, it's almost like the problem had just, jumped sides.
Okay, so on examination at this third hospital, her blood pressure was still a little high. And just like before, she had a clear weakness in her right eye's ability to move outwards, that abduction deficit again.
Sixth nerve palsy again, but on the right.
Exactly. Her inflammatory markers, ESR and CRP, were again mildly elevated, but not dramatically. Routine blood work was normal, and they also tested for Lyme disease, which came back negative.
Okay, good to rule out Lyme.
Definitely. So the doctors are now faced with this recurring pattern of neurological symptoms, shifting sides, still without a really clear underlying cause. What did they do next to try and get some answers?
Well, at this point, the doctors at the third hospital decided to take a closer look at the imaging that had been done during her first hospital visit a couple of months prior.
Reviewing the previous scans. Good idea.
And this is where some more specific clues started to emerge. The initial head CT on review showed some subtle changes described as stranding in the fatty tissue behind her right eye, the intraconal fat.
Okay, subtle, but maybe something.
It wasn't clear-cut, but it was something. And the MRI scan of her head, neck, and orbits, done with contrast, provided even more important information.
What did that show?
It showed abnormal enhancement and edema swelling not just of the right optic nerve, but also the tissue surrounding it.
Okay, inflammation back there.
But T, and this is a really key detail, when the radiologists looked very closely, they noted this swelling and enhancement primarily involved the sheath of the optic nerve, the outer covering, and the fat behind the eye. It seemed to be largely sparing the nerve fibers themselves.
So paraneuritis, inflammation around the nerve rather than neuritis. Inflammation of the nerve itself. That's a critical distinction.
Hugely important, as it turned out. Interestingly, the MRI also showed some mild swelling and enhancement around her left temporomandibular joint, the TMJ.
Which could potentially explain that earlier jaw pain she'd mentioned on the left side.
Could be. The MRI also picked up those non-specific bright spots in the white matter, likely just chronic small vessel disease, not uncommon for her age. So the imaging was finally starting to point towards a specific area of involvement, the optic nerve sheath and surrounding tissues.
Okay, that's a big step forward. So given these new imaging findings suggesting active inflammation around the optic nerve sheath, what did they do?
They decided to treat her with intravenous methylprednisolone, a powerful 4V steroid, hoping to reduce that swelling quickly.
Makes sense. Hit it hard with anti-inflammatories.
They then transferred her to the neurology unit of the third hospital for a more in-depth investigation. By this point, she was still experiencing the double vision and pain when she tried to look to her right, but thankfully, the headache had subsided with the steroids.
Okay. And during this admission, did any other pieces of her history come to light?
Yeah, during this hospital stay, she mentioned a few other things that, while seeming maybe minor, could be important pieces of the puzzle.
Like what?
She reported a recent mild flare-up of that ring-shaped rash she'd had earlier.
Oh, the rash came back. Interesting.
Yeah, mildly. And some recent hair thinning. And also a history of Raynaud's phenomenon.
Raynaud's, where the fingers change color in the cold, that can be associated with autoimmune conditions.
Exactly. Otherwise, when the doctors went through a really comprehensive review of her systems, she didn't report any other significant symptoms. So they're starting to build this more complete picture.
Okay, so let's talk about her background. What did they find in her past medical history?
Well, to get an even broader understanding, the doctors really dug in. It turned out she had a history of Graves' disease with orbitopathy, that's thyroid-related eye disease.
Ah, Graves, that's autoimmune.
Right, but that had been diagnosed and treated successfully over 20 years prior. She also had hypothyroidism, high blood pressure, high cholesterol, acid reflux, had her gallbladder removed, a hysterectomy but kept her ovaries, and a history of breast cancer, estrogen-progesterone positive, had a lumpectomy. But recent scans were normal.
Okay, so several things, including a significant autoimmune history with the Graves.
Definitely. She had also had her COVID-19 vaccines. Her current meds included atorvastatin, amlodipine, levothyroxine for her thyroid, and tamoxifen for the breast cancer history.
And that hydrochlorothiazide rash was noted too.
Yes, that was clearly documented. Lifestyle pretty straightforward, lived in coastal Massachusetts, rarely drank, no tobacco or other substances. Family history included a maternal aunt with thyroid disease.
More thyroid autoimmunity in the family.
And a child with vitiligo.
Vitiligo, another autoimmune condition affecting the skin. Okay, so there's definitely a pattern of autoimmunity in her personal and family history.
For sure. Now, the physical exam when she was admitted to this third hospital reviewed a few key things. Vitals generally stable, blood pressure still a bit high. Doctors noted some scattered red spots on her abdomen, including near the old biopsy site, and a few small dilated blood vessels on her face, telangiectasias. Importantly, no rash on her face or scalp, no sclerodactyly, which is skin thickening. Hair looked normal, eyes showed no redness, but when they tested her eye movement, her right eye had that restricted and painful abduction, couldn't move it outwards fully.
Still the sixth nerve palsy on the right.
Yep. No bulging eyes or eyelid lag, which you might see with active thyroid eye disease. Her vision was a bit reduced in the right eye, 20/40, and she had trouble seeing red clearly with that eye red desaturation.
Suggesting the optic nerve was affected functionally, even if the sheath was the main site of inflammation on MRI.
And notably, the optic disc in her right eye appeared paler compared to the left.
Paler disc can indicate some chronic nerve damage or atrophy.
The rest of her physical exam was unremarkable. So we have this collection of seemingly disparate findings. Could they all be connected somehow?
That's the million-dollar question. So they ran a whole battery of tests at this third hospital to try and find that connection.
Right. EKG was normal, basic blood work, CDC, electrolytes, calcium, albumin, globulin, all normal. Interestingly, her ESR, which had been slightly up before, was now quite low, only 6. And her CRP was also low.
Huh. Inflammatory markers went down? Maybe due to the steroids she received in the ER?
Possibly. They tested for a wide array of infections, hepatitis B, C, HIV, Lyme again, syphilis, all negative. They checked for VZV, the shingles virus. She had past exposure antibodies, IgG, but no sign of active infection, IgM negative.
Okay, ruling out active infections.
Tests for COVID, TB, drug screens were also negative, so systematically ruling out infectious causes.
Good. Given the neurological symptoms, did they do a lumbar puncture, check the spinal fluid?
They did. The CSF, cerebrospinal fluid, appeared clear. Opening pressure was normal. Only found rare mononuclear cells, no organisms seen on the gram stain. CSF glucose and protein levels were normal. No abnormal cells detected.
So the spinal fluid analysis didn't really point towards an infection or a primary CNS inflammatory condition like meningitis or encephalitis. Pretty unremarkable, LP.
Seems so. The investigation continued. They ran even more specialized tests. Antibodies for Bartonella, ACE levels, sometimes elevated in sarcoidosis, complement components C3 and C4, serum-free light chains, serum protein electrophoresis, urinalysis, all normal.
Casting a very wide net.
A very wide net. Her level of IgG4, a specific antibody subtype, was mildly elevated at 137.3. The upper limit of normal is often around 135.
Okay, mildly elevated IgG4. Something to note, maybe, but not definitive for IgG4-related disease on its own.
Right. Tests for lupus anticoagulant and related antibodies were negative. CSF checks for Cryptococcus and active VZV were also negative. It's like they're checking everything.
Trying to leave no stone unturned. What about more imaging?
They did repeat and expand the imaging. A chest CT with contrast didn't show any enlarged lymph nodes, which could suggest lymphoma or sarcoidosis, but it did show some fatty liver and a tiny 2-millimeter nodule in her right lung apex. Probably incidental.
Likely. And more MRI.
MRI of the head and the entire spine with contrast confirmed that asymmetric enhancement around the optic nerve sheath on the right, both in the orbit and within the bony canal. Still mainly the sheath and surrounding fat. Importantly, no abnormal enhancement in her spinal cord.
So the problem seems confined to the orbital apex area, primarily on the right.
And one more thing. They did an ultrasound of her temporal arteries.
Looking for giant cell arteritis.
Exactly. And that was normal. No halo sign.
Okay, makes GCA less likely, especially with normal inflammatory markers now.
So let's just pause and recap here. We have this 67-year-old woman with a really perplexing series of symptoms. Shifting cranial nerve palsy is affecting her eye movements, clear inflammation of the optic nerve sheath on imaging, a past history hinting at autoimmune issues, and this mix of mostly normal but a few slightly odd lab results, like the mild IgG4 elevation and those earlier positive ANAs.
It's like all these puzzle pieces are scattered on the table.
Yeah. The crucial question now is, what single underlying condition can possibly connect all of these seemingly unrelated dots? What could be the unifying diagnosis?
Well, let's think through the possibilities the doctors were likely considering. That initial rash, plus the positive ANA and anti-SSA antibodies found earlier, did make them think about autoimmune conditions.
Like lupus.
Like drug-induced subacute cutaneous lupus, potentially triggered by the hydrochlorothiazide. But as we discussed, the skin biopsy wasn't really a perfect match for that. So while it was a thought early on, other findings didn't quite fit.
Okay. And that alternating sixth nerve palsy, affecting one eye, then resolving, then hitting the other, that was a bit of a diagnostic head-scratcher in itself, right?
Absolutely. Initially, the first episode on the left was put down to a possible microvascular issue, a small blood vessel problem.
Which is common, as you said.
Right. But the recurrence on the other side, weeks later, makes that explanation less convincing. Just bad luck striking twice, same nerve, opposite sides. Seems unlikely.
Yeah, feels like something systemic might be going on.
Exactly. And the later presentation with the right eye involvement, including not just the muscle weakness, but also signs of optic neuropathy, the color vision change, the pale disc started pointing towards something called orbital apex syndrome.
Which means problems affecting the structures at the very back of the eye socket.
Correct. Nerves, blood vessels back there. But the question remained, what was causing it in her case?
And that key distinction you mentioned earlier became critical. Was it optic perineuritis, inflammation of the sheath, or optic neuritis, inflammation of the nerve fibers?
Precisely. Primary optic perineuritis, the kind without a known cause, is usually just one eye. When it's bilateral, or alternating like this, or associated with other nerve issues, it waves a big red flag.
A red flag for what?
For needing to look deeper for underlying causes, infections like syphilis, TB, herpes, systemic autoimmune diseases, which seemed more likely here given her history, or even though less common, malignancy. Figuring out where the inflammation was focused helped narrow the search.
So conditions like MS or NMOSD became less likely?
Correct. Demyelinating disorders like multiple sclerosis and neuromyelitis optica spectrum disorder usually cause more inflammation within the nerve parenchyma itself, not predominantly the sheath. Plus, the orbital soft tissue swelling and the eye movement problems aren't typical features, so the focus shifted more towards other autoimmune possibilities.
Okay, so back to things like Graves' SLE, maybe MOG antibody disease.
Exactly. They can all involve optic perineuritis. She had the Graves' history, the family history of vitiligo, those positive and anti-SSA. So could her thyroid eye disease have reactivated?
Is that likely?
It was considered, but the timing of her COVID vaccine was pretty distant. And crucially, she didn't have the characteristic enlarged eye muscles usually seen in active thyroid eye disease on her MRI.
Okay, so probably not Graves' reactivation. Infections were ruled out. Cancer, malignancy was still a possibility, but they wanted to pursue autoimmune inflammatory causes first.
Right. And while the ANA was positive, she didn't really have the full clinical picture of SLE, and other specific lupus antibodies were negative, so SLE wasn't looking like a strong fit.
What about that positive anti-SSA antibody? Could that point toward Sjögren's syndrome?
That was definitely a consideration. Neurologic Sjögren's can cause cranial neuropathies, sometimes even before the classic dry eyes and dry mouth symptoms appear. But you'd still want to specifically test for and rule out an MOSD and monoantibody disease with their respective antibody tests.
Okay. What else was on the differential list? Neurosarcoidosis.
Neurosarcoidosis can cause cranial neuropathies, yes, but it usually involves the lungs, and her chest CT was pretty clear. The mildly elevated IgG4 raised the possibility of IgG4-related disease, which can involve the orbit and optic nerve, but that test isn't very specific on its own. Further workup, like a PET scan, might be needed if other tests were negative.
Right. So that leaves vasculitis, inflammation of blood vessels.
Exactly. Conditions like giant cell arteritis, GCA, or ANCA-associated vasculitis can cause optic paraneuritis. However, her mostly normal inflammatory markers now and the lack of widespread systemic symptoms made typical presentations less likely. Plus, the negative temporal artery ultrasound argued against GCA.
But you mentioned one specific type might still fit.
Yes, optic paraneuritis is increasingly recognized as a potential manifestation of granulomatosis with polyangiitis, GPA, one type of ANCA-associated vasculitis, and sometimes it can present in more limited forms without all the classic systemic signs.
Okay, so that remained a possibility.
It did. So given this remaining possibility, with many other conditions looking less likely, the medical team decided to order a very specific diagnostic blood test.
The crucial test we hinted at earlier.
The crucial test. What was it, and what did it reveal that finally unlocked this whole complex case? We'll have that answer for you right after this quick break.
Welcome back to the deep dive. We've been meticulously following the diagnostic roller coaster of a 67-year-old woman with baffling, shifting eye symptoms. Before the break, we were right at the edge. The medical team ordered a specific test. So what was this key test?
The crucial diagnostic test that finally broke the case open was a serum ANCA test. That stands for antineutrophil cytoplasmic antibody.
ANCA. Okay, let's unpack that. What exactly are these antibodies? What do they tell doctors?
So ANCAs are autoantibodies. Basically, the immune system messes up and creates antibodies against components of its own cells, specifically proteins found inside neutrophils and monocytes, types of white blood cells.
Attacking its own immune cells.
Sort of, yeah. Attacking proteins within those cells. While there are different targets, the two most important ones, especially when thinking about systemic vasculitis, are myeloperoxidase, or MPO for short, and proteinase 3, or PR3. The ANCA test looks for antibodies specifically targeting these MPO and PR3 proteins.
Okay, MPO and PR3. So how do they actually test for these ANCAs in the lab? Is it just one test?
It's usually a two-step process. First, there's something called indirect immunofluorescence, or IIF. They take the patient's serum, put it on a slide with normal neutrophils, and use fluorescent tags to see if antibodies bind and where they bind within the cell.
And that gives different patterns.
Exactly. You might hear terms like CANCA for cytoplasmic pattern or PANCA for perinuclear pattern. This gives an initial clue.
But it's not the whole story.
No, because sometimes other antibodies, like the ANA antibodies this patient had earlier, can interfere and cause a misleading pattern, especially a false positive PANCA. So the second step is crucial. That's an antigen-specific ELISA, enzyme-linked immunosorbent assay. This test directly measures the levels of antibodies specifically against MPO and specifically against PR3. It's much more precise and confirms the finding.
Gotcha. So what were the results of this critical two-step ANCA testing for our patient? What did it finally reveal?
Okay, so her initial indirect immunofluorescence, the ICIF, showed a PANCA pattern.
The paranuclear pattern.
Right. And then the ELISA, the specific test, came back strongly positive for MPO antibodies. Her level was 23 units, where the normal is less than 2.8.
Wow, significantly elevated MPO ANCA.
Definitely. And importantly, she tested negative for the PR3 antibodies. So the key finding was MPO ANCA positivity.
A positive MPO ANCA result. What does that strongly suggest to the doctors? What condition is it linked to?
A positive ANCA test, especially for MPO or PR3, is a major indicator for a group of autoimmune conditions called ANCA-associated vasculitides.
Vasculitis, again, inflammation of blood vessels.
Yes, systemic diseases causing inflammation and damage to primarily small blood vessels throughout the body. There are different types, like granulomatosis with polyangiitis, GPA, microscopic polyangiitis, MPA, eosinophilic granulomatosis with polyangiitis, EGPA. MPO antibodies, like our patient had, are most commonly associated with microscopic polyangiitis, MPA.
So this positive test was a huge breakthrough.
Absolutely. It provided a potential unifying diagnosis for her seemingly disparate symptoms.
Is a positive ANCA test enough on its own to diagnose vasculitis? Or do you still need other evidence, like a biopsy?
That's a great question. Ideally, the gold standard is often a tissue biopsy showing vasculitis. However, in many cases, especially when a patient has suggestive clinical features, a strongly positive MPO or PR3 ANCA test is considered highly diagnostic and an acceptable alternative.
So the test is pretty reliable.
Yes, studies show that the combination of IF and the specific ELISA has high specificity, meaning it correctly identifies those without the disease, and good sensitivity, it picks up most people with the disease. A positive result, especially matching the clinical picture, really boosts the probability of ANCA-associated vasculitis.
Okay, so bringing it all back to our patient.
Mm-hmm.
How did this positive MPO ANCA result finally connect with those weird alternating eye symptoms, the nerve sheath inflammation?
Well, her specific presentation, the alternating sixth nerve palsies, the optic paraneuritis seen on MRI, while maybe not the most classic textbook presentation of MPA, are definitely recognized manifestations of ANCA-associated vasculitis. So putting together her unique constellation of symptoms with that positive MPO ANCA test, the final diagnosis became clear.
Which was?
Myeloperoxidase antineutrophil cytoplasmic antibody-associated vasculitis, or MPO-ANCA-associated vasculitis. In her case, it was manifesting primarily as this orbital apex syndrome with optic paraneuritis. The pieces finally fit.
Wow, okay. So once they had that definitive diagnosis, what was the immediate game plan? How do you treat something like this?
Right, so the first step after diagnosis is always to figure out how widespread and severe the vasculitis is. Are other organs involved, like the kidneys or lungs?
And in her case?
In her case, thankfully, it seemed primarily limited to the right optic nerve involvement and the sixth nerve palsy. No clear evidence of major kidney, lung, or other organ damage, which is relatively good news in terms of prognosis.
Okay, so the treatment goals.
The main goals are twofold. First, induce remission, get the inflammation under control quickly to stop any further damage. Second, prevent future relapses and long-term organ damage, all while trying hard to minimize the side effects from the strong treatments needed.
And what specific treatments did she actually receive?
She was started immediately on high-dose intravenous methylprednisolone therapy steroids to knock down the inflammation fast.
Standard first step for severe inflammation.
This was followed by high-dose oral prednisone, which was then gradually tapered down over several months. Interestingly, the way they taper steroids now is often guided by newer trial data, like the PEXVIS trial, aiming for lower cumulative doses to reduce steroid toxicity if possible.
Makes sense. Steroids have a lot of side effects. Was that it, just steroids?
No, for remission induction in serious ANCA vasculitis, you usually need more than just steroids. She was also started on rituximab.
Rituximab. What's that?
It's a biologic medication, an antibody therapy that targets and depletes B cells. B cells are the immune cells responsible for producing antibodies, including those harmful ANCAs.
So it gets at the source of the autoantibodies.
Exactly. Rituximab is often chosen now based on major trials showing it's as effective as the older drug cyclophosphamide, but generally has a better long-term safety profile. Guidelines from groups like the American College of Rheumatology often recommend it.
Okay. Any other treatments considered?
There's a newer drug called avacopan, which targets a different part of the inflammatory pathway and can help spare steroid use. It was recommended, but apparently wasn't obtained due to cost issues, which is unfortunately common with some newer medications.
Right. What about plasma exchange?
Plasma exchange, or plasmapheresis, is sometimes used in very severe cases, particularly with rapidly worsening kidney function or lung hemorrhage, but it wasn't indicated here since her kidneys seemed okay.
And because these treatments suppress the immune system, did she need preventative meds?
Yes, absolutely. She was started on medication to prevent pneumocystis jirovecii pneumonia, or PJP, which is a risk with immunosuppression, and also calcium, vitamin D, and alendronate to help prevent osteoporosis, a known side effect of long-term steroid use.
Did she experience side effects from the treatment itself?
Unfortunately, yes. High-dose steroids especially can be tough. She experienced insomnia, trouble concentrating, increased appetite, hyperphagia, facial swelling, tremors, and even developed a new episode of atrial fibrillation, an irregular heart rhythm which can sometimes be triggered by steroids.
Wow, so managing the treatment side effects is a big part of this too?
Definitely. It's always a balance.
But despite those challenges, it sounds like the treatment ultimately worked for the vasculitis itself.
Yes. Thankfully, the outcome was very positive. About 4 months after starting this intensive treatment regimen, a follow-up MRI of her orbits came back normal.
No more inflammation.
No signs of active inflammation, and her ophthalmologic exam was also normal. Her symptoms were in complete remission. Plus, her MPO-ANCA level had dropped significantly down to 2.3, back into the normal range.
That's fantastic news.
It really is. The
Yeah.
plan was to continue her on maintenance therapy with rituximab, given at less frequent intervals, to keep the disease suppressed and prevent relapses long term.
So looking back at this whole intricate case, what's the big takeaway? What's the most important lesson here?
I think this case really underscores the incredible complexity sometimes of medical diagnosis. It just highlights how seemingly disconnected symptoms, the rash, the shifting eye problems, the jaw pain, and maybe subtle lab or imaging findings can eventually converge to reveal a serious underlying condition.
Like putting together a really tough puzzle.
Exactly. Those alternating cranial nerve palsies, which were so perplexing initially, turned out to be absolutely critical clues that, when combined with that positive ANCA test, pointed squarely at ANCA-associated vasculitis.
So don't ignore weird patterns.
Right. And it really emphasizes how important it is for clinicians to consider systemic autoimmune diseases, even when the symptoms first appear quite localized, like just affecting the eye in this instance. You have to think broadly. And finally, it just powerfully demonstrates the crucial role that specific blood tests, like the ANCA assay, can play in unraveling these challenging medical mysteries. They can provide the key to unlock the diagnosis and lead to effective, sometimes life-saving treatments.
It really makes you think, doesn't it? How many other seemingly isolated or just, odd symptoms might actually be the first whispers of a much broader systemic illness, just waiting for the right pieces of the puzzle and maybe the right test to fall into place. Thanks for taking that deep dive with us today.